One thing that we need really to learn from is that I think the ethics of work in the workforce, in the health profession in South Africa has changed a lot. And I think we need to all address that, whether it's from the private sector or not, because when you hear about the complaints from patients, it's always about their dignity, it's always about delays, it's about the rudeness of the health professionals and so on. I think those are issues really we can take care of that are within our control, and I think we must address that.
Sometimes we get sick and then we're being afraid to go to hospitals or clinics because we know how rude they are. They don't do their work with like open hearts and dedication. Like they don't help community. You know, when you say you want to be a doctor or a nurse, you have to it's more like delivering to the community, helping the community and all that. But they don't do that. They're dragging their feet.
The service is very weak. Probably it's pathetic to see that people go to the clinics and the people say they must use the traditionally medicines at home. People go for, as you can see, treatments, but at the end of the day, they sit in clinics for a time being, and waste of time, waste of money, because at the end of the day, they come out with the clinics without help.
I think that the new plan, I don't know, the minister that brings that new plan into effect, I don't know how it's going to work if you don't start at ground level. And I think on paper it looks very good, but I think the facility itself as it is now, it is very poor.
According to the World Health Organization, at least half of the world's population do not have coverage of essential health services, and this remains a critical issue worldwide. As a result, the concept of universal health coverage remains a crucial part of the Sustainable Development Agenda, the commitment to ensure that by 2030, each person has access to quality health care without suffering any financial hardship. Health Talk attended the 19th Annual Board of Healthcare Funders Conference on Universal Health Coverage, where the theme was Putting the Healthcare Citizen First. So our topic for today then is Universal Health Coverage. We've packaged some leading thoughts and opinions from this conference, after which we have a panel to help us further unpack this topic. Now, this panel is comprised of the Head of Health from Section 27, and from our studio in Pretoria, the Deputy Director General for NHI at the National Department of Health. So be part of the show by asking the panel some questions or simply just sharing your views with us. The number to call is Johannesburg 714-6918 or 6919. You can also tweet us at SABC Health Talk, or simply just interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show ahead, coming to you just after a short break. I'm Dr. Sello Madaung, and this is Health Talk.
One's life can change in an instant. It is then that you need fast and efficient service. And that is why Asapol created the Instant Groceries benefit for you. Minutes after a claim, an electronic voucher for 2,500 Rand will be sent to your cell phone. And within an instant, you can start doing shopping at all the major stores. More than 700,000 customers have already received the Instant Groceries benefit. Get yours in an instant. SMS call to 32813.
Violent protests have spread throughout the province for a second week now.
It shows that the ANC here cannot put the people first, and services have failed here. That's why this Northwest becomes a very important province.
Ek wil mos kak praat. Kom. Niks. Ja. Hoor in die bakkie is 'n laite. Kom, maak sit in jou kop, fuck.
Manesa shota haholo. Le manesa ona ha tse bua le gona hantle.
At the end of the day, babang ki di maternal death and all that, we are to be blamed because of overcrowding of the patient.
I will build a great wall on our southern border, and I will have Mexico pay for that wall. And nobody builds walls better than me, believe me.
So I had an opportunity to spend some time with Professor Malagapuru William Makgoba, the Health Ombudsman in the Office of the Health Standards Compliance. as he shared his views on the state of healthcare in the country and the significance of universal health coverage. Take a listen. Drawing from your experience, let's unpack this, concept of universal health coverage, drawing from your experience in the UK.
The NHS was really established by a British MP called Aneurin Bevan on the 5th of July 1948. And it was premised on the idea, or it came out of the Great Depression and poverty in the UK and generally in the West, where people were poor, death rates were going up, access to health was only to the rich and the poor were not getting access, and the levels of inequality in the world had increased. It was obviously a difficult time, I think, for the empire at the time, but for Britain in particular. And this concept of the National Health Service was introduced. It is now been given a new name through the United Nations and through the World Health Organization to be the model of the so-called universal health care. It is the trend in the world, and South Africa should be part of that trend. And I think the most important really thing I want to emphasize is that if we're going to deal with the issue of poverty, squalor, inequality, unemployment, inequitable health care in our country, to improve the dignity of people, there is only one option we have, and that option is the option of the National Health Insurance.
So there are interesting parallels then between the UK system and the South African system, because it appears that the UK went through exactly the same issues that we're going through currently.
We are only 70 years behind the UK, and many countries are many years behind the UK. Remember, Obamacare only came into being maybe about, I would say, 10 years ago when Obama was president, or when towards the end of his presidency. So that was the Americans trying to adopt a form of universal health care. But it is a trend in the world, as I say, that has the stamp of the UN in the development goals of the SDGs, and also the Millennium Goals, I think, were captured in there. But remember that in our own country, 3 years before the SDGs of the UN, we already had a national development plan in which the national health insurance or universal health care was already approved nationally by our parliament through the national development plan. So we have it entrenched. We shouldn't be debating whether to have it or not to have it. I think what we can be debating is how it is best articulated or translated on the ground. And that's really, I think, the domain of the national minister.
Let's assume that we don't have any options. We just have to go forward and achieve universal health coverage. And let's look at what needs to be done to achieve this, perhaps starting with the structural issues, starting with healthcare systems themselves.
Well, I think, as I indicated in some other aspect, is that I think we all agree that our health system is problematic. Our national minister does not have the powers that he is supposed to have. And this is the way I think the policies or the constitution is being translated through the various provinces and municipalities. We have several tiers. We have the national, we have the provincial, and we have the municipalities. Each one of these have got powers that are often don't talk to each other. I think the classic example everybody says is that the national minister does not appoint the MECs, and therefore, the MECs do not report to him. The national budget gets set and immediately it gets distributed to the province. And the national minister has got very little to do with what happens there, although I think you can, if you look into the constitution broadly, you may find a way of dealing with that. I think that's the one level. Then we have the private and the public. And the interests of the two are not the same. You know, the public is trying to address the national issues of poverty, inequality, and unemployment. The private sector is just the opposite. I mean, they are entrenching inequality into the system, and they are doing that very forcefully. They use what I call clever speak and clever legalese, but actually they are going against the Constitution. So we need to agree that whether it's private or public, the answer to our national questions of poverty, unemployment, inequality is the national health insurance, which the current minister has been championing, I think, over the last 7 or 8 years since he has been minister.
So let's talk about the concept of equitable access, perhaps starting with quality, because clearly there are differences between the private and the public sector insofar as quality is concerned.
There is perceived. Yeah, it's perceived differences. I'm not sure that even our private sector has the quality that it is promoted to be. I think there are issues of quality in that sector in many ways. I think if you were to look at, for example, from the Office of the Health Ombudsman, if you were to see the complaints that are coming from patients about the private sector, you will realize that actually the quality of their service is not as good as it's meant to be. I think I can go into the details of that. So I don't think we should be bending around that they are of high quality. Of course, as I say, the public sector has the mandate of the public to address the fundamental issues of our nation, which is partly and largely to transform the health sector to become equitable. And the one way to do it that we have all looked at, including the private sector, is that the national health insurance, or the equivalent of the National Health Service, is what we need. We do recognize that I think in both sectors there are problems of infrastructure. In both sectors there are human resources issues. In both sectors there are issues of ethics of how the professions in the sectors conduct themselves. There are also financial issues that either relate to the clients that are involved there or relates to the fees that are being charged that are quite different, and that makes the system inequitable. And as I say, the National Health Insurance addresses that. Of course, I think as a country we are engaged in the debate of how best to address the National Health Insurance.
So you said earlier that the two sectors have similar kind of problems, or there are issues on both sides. Infrastructure, quality. There's perceived abundance in the private sector as compared to the public sector in terms of infrastructure. What can be done to address these?
Well, I think it has got to be sorted out at the level of policy. I mean, there has to be a policy, and that policy obviously is based on the constitution of the country. I think it must derive from the Constitution, the National Health Act, and all of those are what the Minister of Health should lead, I think, in transforming the old policies. Because at the moment, the system as is, it's really just a slight version of what used to happen in apartheid. And I think we haven't really shifted in line with where we should be, in accordance maybe with the National Development Plan, or even just in terms of the changes that are expected by the public sector. But also remember that the private sector, although it gets almost similar resources, it looks for almost like 10 to 15% of the population, while for the same resources, the public sector looks for about 85% of the population. And therefore, there is no equitability in terms of simply just the financial resources and the sheer, I think, numbers that have to be dealt with. But let's not also forget that the private sector actually uses the public institution also to look after itself. So if there are problems of infrastructure in the public institution, they affect the private sector. That's why I'm saying this issue of quality of one as opposed to the other, it's fuzzy and not truthful and would not stand scientific scrutiny.
So you said that we're 70 years behind the UK insofar as, establishing universal health coverage. What lessons can be learned from the UK experience in South Africa?
I think the lessons we can learn is that the principle of universal health care, it's here to stay, and we must accept it nationally as it has been proposed in the National Development Plan and as it's being championed by the current minister. That's the first. The second is that even in 70 years of the National Health Service, there are still challenges of how to operationalize the national health system in terms of its manpower, in terms of its financing. As it happens, I used to work for somebody who was actually in the committee of the manpower planning of the NHS. So I was doing the little research for my boss, but I didn't realize that it would assist me, I think, coming back to South Africa. So there are issues of that. The one thing that we need really to learn from is that I think the ethics of work in the workforce, in the health profession in South Africa has changed a lot. And I think we need to all address that, whether it's from the private sector or not, because when you hear about the complaints from patients, it's always about their dignity, it's always about delays, it's about the rudeness of the health professionals and so on. I think those are issues really we can take care of that are within our control, and I think we must address that. But I think at the end of the day, in order to address inequality in health, poverty in health, death rates in health, disparities in health, there is one solution. It is the national health insurance, and I think we must support that.
And how confident are you that we'll finally get there?
Well, I think we defeated apartheid. So what is this? This animal can also be defeated. I think if we are resolved and we bring all the manpower and the brain power of the country and we listen and talk to each other, I think we can solve this, I think, for the betterment of our own country. But the UK has shown that through the National Health Service, you can reduce poverty, you can improve dignity, you can treat people irrespective of their earning, irrespective of their social class. You can treat somebody in London who's from Scotland irrespective of what they earn, and that's what we used to do. And equitability in the health system has to improve from where it is right now. At the moment, I think we are still way behind. We've made a start, but we are spending so much energy arguing about things we shouldn't be arguing about.
All right, there was our health ombud, Professor Malgapuru William Makgoba. Okay, time for a quick break. After that, we discuss universal health coverage in the SADC region and the impact in the African continent. Please stay with us.
The United States will not be a migrant camp, and it will not be a refugee holding facility. It won't be. We can't allow that to happen to the United States, not on my watch.
The N2 is currently closed between the Garden Road Mall as well as Pagalstop due to a violent protest that is taking place inside Thembalethu. The residents are demanding services.
Mr. Willems elected not to participate in this investigation. We have gone out of our way to appoint an independent somebody to look at this matter.
It's important for us to not close the door on Ashwin because we still believe that he's got a lot of value to add.
dose of art and entertainment news. Tune into Trends every Saturday from 12 to 1.
Welcome back. Now, I also spoke to Dr. Amit Thaka, chairman of the African Health Federation based in Kenya. Now, he shared his views on collaborations in Africa in a quest to achieve universal health coverage. Please watch this. This conference has focused a lot more on collaboration and partnerships in terms of achieving universal health coverage. Now, the advantage with you is that you look at the region, the SADC region or Africa as a continent. Let's start with policy around the issue of universal health coverage. What sense do you get about commitment to health coverage, universal healthcare coverage in the region?
It's extremely high. It's never been higher than what it is now, commitment to universal health coverage. Most countries, almost 17 countries in Africa, have a bill in parliament that is looking at making universal health coverage a reality. There are about 5 or 6 countries that have experimented at a very wide level in universal health coverage. So the commitment is high. And all of them are facing different challenges, and there have been variations in which some of the countries have adopted universal health coverage within Africa.
Okay. Talk about challenges. I mean, clearly there's different challenges.
Correct.
And the one common challenge is inequity in access to healthcare coverage. Any differences, any that you've seen? I mean, you've had countries like Rwanda, for instance, that has been a shining example in terms of, being what some people might describe as being miles ahead of the other countries in the region. Will you comment on that?
Yeah, so, there are several studies done. The one by Yates that was released in 2017 showed 5 countries in Africa that were facing different challenges and had taken different models. So the cross-cutting challenge that we have seen in all the countries in Africa that's going through universal health coverage is access to finance to bridge the inequity that you talked about. And the second cross-cutting challenge has been infrastructure and human resources for health. So these 2 challenges are the ones that are creating the largest burden for countries to achieve universal health coverage. So let's talk about financing. The biggest problem that we have in policies being churned out on UHC in Africa is the fragility that we have of the formal sector. You will see, even in South Africa and in Kenya and in Ghana, they tend to easily try and get more tax from the formal sector to try and look after the ones who are either not employed or in their informal sector. And the ratio is too wide. There are too few formally employed people in most of the African countries. That's one challenge. The second challenge has been adopting a tax which can be applied across a certain format, such as sin tax. It could be alcohol, it could be cigarettes, it could be sometimes hinging into pension funds. These taxes also have sometimes a negative impact on economic growth. For example, when Ghana introduced a 3% health tax, there were other consequences that the country had to face. Rwanda, on the other hand, is very donor dependent. And they were very clear about this, that for the 11 million people in Rwanda, we want to make healthcare a priority. And to enable them achieve that, they had to have a lot of donor funding, almost 60% donor funding, that makes that scheme sustainable. But what Rwanda did, which I think was a shining example which all the African countries should take, is they identified the poor, which we sometimes make a mistake with. When we identify the poor and the vulnerable and those who can't pay for any health care in our country, that is the responsibility of the state. It's clear. And most of the countries try and shy away from it because they know it's only the state who will have to look after them. It is the state's responsibility to look after the poor and vulnerable. Most countries at the moment are debating on how to receive more funding from the private sector without applying the resources from the public sector. It has to be both ways for UHC to succeed.
Yeah, I suppose these challenges are interrelated. I mean, we've spent quite a bit of time on financing, but on the other hand, it's the structures or the healthcare systems in the individual countries. Let's make an example.
Yes.
Here in South Africa,
okay,
we have a private sector that is distinct, from the public sector. So how can these challenges around the structure of the healthcare system be tackled in order to ensure that we achieve universal health coverage?
I think the issue has always been quality. If you ask anybody in Africa that if you had money, would you go to the public sector or the private sector? What would they say? And that's been where the problem is. We have not focused on the quality of services in our public institutions. That's been where our health systems have collapsed. And yet, you have the brightest professors and the brightest doctors in some of these public institutions. What happened? When did the rain start beating us? We should ask. And that's been the dichotomy, that when I'm in the private sector, when I see more patients, I'll get more revenue. When I'm in the public sector, when I see more patients, it's a drain of the revenue. So it's a reverse of the financial incentive. We can fix this by focusing on improving quality, improving rewards, and motivating the public sector on providing better healthcare. In fact, with the limited resources, the amount of waste that goes on in some of the sectors is what makes the quality be where it is. Now, talking about private sector, I think that if we wasted resources in the private sector, the companies go bankrupt. So there is what you call a market force that determines that private sector have to be efficient. So that's where the difference is when it comes to resource utilization.
We know that there's commitment and there's the will from most countries in the region, but there's a need to continue to entrench that message of universal health coverage. So what are the sort of activities that are planned, perhaps, increasing on awareness? I heard, just outside this interview, you're talking about a summit that you're going to be having in South Africa in October. Just tell us a little bit about that.
So, this movement started 14 years ago, and many countries have adopted the fact that PPP and partnerships is important. So we have Ghana, Nigeria, Ethiopia, Kenya, Rwanda, Namibia. These are countries that have already made some kind of a healthcare federation. In 2016, it was very clear that there's a lot we can do in inter-Africa trade and services by collaborating amongst ourselves. So we don't have to import all the personnel, all the goods, and all the medicines, and there's a lot we can learn in best practices. So we launched the Africa Healthcare Federation, which is supported by the Africa Union, and it has an annual event trying to foster partnerships and investments. So we've had the first one in Nairobi, and the second one is in Dakar, and the third one, because it's rotating in all the 5 regions, is in South Africa, in Johannesburg, on 8th and 9th October at the Grand Hyatt in Rosebank. We're expecting 15 ministers of health, WHO Director General Tedros, and many champions in the industry from the public and private sector to sit for a 2-day event discussing universal health coverage.
We certainly will look forward to that summit. There was Dr. Amit Thaka, Chairman of the African Health Federation. So the question then is, what needs to be done to ensure that universal health coverage is achieved? Well, that after the break. Please stay with us.
We visit all the best spots for some live jazz performances. Traveling to breathtaking holiday destinations is what we like doing. Enjoying outdoor adventures with family and friends. Relish global cuisines.
Part of cooking.
For all the tourism, delicious cuisines and outdoor adventures, join us on Trends Travel every Sunday at 12 o'clock right here on the SABC News channel.
Hello, I'm Simpiwe Ngongwane, and as usual, I'm in the company of the pearl of the show.
And yes, I'm Pearl Shongwe, and this is the weekend edition of Morning Live,
where we bring you news stories, making headlines, weather updates, and the latest in the world of sports.
Every weekend on Saturday and Sunday mornings, we bring you, our viewer, vibrant, exciting, informative current stories here on the SABC News Channel 404.
And we also put a spotlight on creative art stories, book reviews, poetry, and various topical stories. We also bring you live outside broadcast as well as live music performances. All of this every weekend between 6 and 9 here on the SABC News Channel 404.
Welcome back. So before we answer the question, where to from here, let's listen in on Dr. Clarence Mini, Chairman of the Council for Medical Schemes, Dr. Guni Gulab, Principal Officer of GEMS, and Dr. Katlego Mutudi, Managing Director of the Board of Healthcare Funders. Please take a listen.
As Council, as you know, we regulate 8.9 million people. And we look after that number of people. And we are saying the work we are doing should expand to include the whole country. Instead of looking after 8.9 people, there are 56 million people out there who deserve similar benefits to the ones that we are getting, those that are covered by medical schemes. So we're saying it's about time that this was extended to include even the less fortunate in our populations.
Let me start by saying that we're now 24 years into our democracy, and our constitution requires that we address many of the challenges of our past, in particular the inequality, poverty and unemployment. And in the healthcare space, to bring meaning to our citizens, it's absolutely essential that we address the inequality of the past. This is very clearly demonstrated in our health sector, and going forward now in the context of universal healthcare and NHI, this is a key step towards moving forward.
What are some of your views on universal health coverage, and how feasible and attainable is this considering the country's health system as it stands?
Yes, I think that's a very relevant question, and I would start by saying that globally it's accepted that winning nations move towards universal healthcare. So it's the smart thing to do, it's the right thing to do, and we should all understand that and support that in the interest of the success of the country.
We thought it important that we focus on the recipient of the health services. And we were quite deliberate in saying the health citizen. We did not want to exclude those people who are not currently covered by schemes by referring to them as beneficiaries. So most of the discussions were centered around the work that we're doing in terms of healthcare reform should be all-inclusive and make sure that it is the health citizens that eventually benefit from the discussions. I think when we look at the universal health coverage, it's important to examine what the intention is. The intention is to make sure that everybody in the country receives healthcare services that they require without financial hardship. We fully embrace the concept of universal health coverage. We might not agree on how we are going to implement it, the delivery models, but the main pillars are in place. And we are saying to everybody, all the stakeholders, that let's work together, let's collaborate and say from our own corners, what is it we can do? Even prior to legislative reform or even prior to the bills being published, there are some healthcare reform steps that we can, from our world, that we can start implementing.
All right, so we're going to have a quick chat then about universal health coverage and perhaps answer the question, the most relevant question, where to from here? What needs to be done to ensure that we achieve this concept of universal health coverage? Now, let me introduce, first of all, my guests. Here in Johannesburg, I have Sasha Stevenson. Sasha is the head of health at Section 27. And then in our Pretoria studio, we have Dr. Anban Pillay, who's the deputy director for NHI at the National Department of Health. Both of you, welcome to Health Talk.
Thank you.
All right. Now, Dr. Pile, we'll come back to you shortly, but let's take a caller on the line. I think we have Samki on the line from Durban. Samki, welcome to Health Talk.
Hello, how are you?
We're good. How are you, Samki?
Good, thank you.
Do you have a question or comment for us?
Yes, I do have a question. Well, it's a statement.
Yeah.
So, yeah, I'm a 22-year-old and I'm diagnosed with bipolar.
Yes.
This happened in 2014 and it came to a point where I actually lost my memory. So now, what I wanted to find out is, I go to a public hospital and they're giving me this medication that is actually disabling me. Like this whole side, my right hand, my right side, my left side, sometimes it wouldn't work and I get spasms. And I spoke to my doctor this one time, asking them is it better if I go to a private hospital? But then he told me that they're actually going to be giving me the same medication. But however, with my moods and everything that I go through on a daily basis, when I go to a public hospital, it's not giving me much of what makes me feel better, I think. I'm not sure. Sometimes I would even default because of the seizures that I get. It takes about 30 to 45 minutes for it to numb and for me to get better in my body to absorb, to get better. So now I'm asking, okay, I do understand about the people who can't afford and whatnot and the least that South Africa is doing for those people. But for some people with my condition, what do I do in this state to be okay?
Thank you, Samki. We get the gist of your question. I think the issue here is about perception about quality of service in the public sector versus the private sector. We will address that, and I'll ask a comment or two from our guests. But what I'd advise you to do, if you're not too happy or you're experiencing some problems with the medication that you've been given, the best thing to do is to go back to the doctor that gave you the medication and report that. But stay tuned. We'll try and address that issue of perception in quality. Let's cross over to Pretoria and speak to Dr. Anban Pile. Dr. Pile, you've heard the two interviews that I had, when we were down in Sun City for that conference, which I know that you had an opportunity to attend yourself. Perhaps you might want to start by, if you have any comments on, the interviews that we had, but perhaps start by answering the question, where to from here?
Thank you for the opportunity. So the Minister of Health, Dr. Motsoaledi, has released the National Health Insurance Bill for public comment. This public comment would be for a period of 3 months. We're hoping that the public will engage with the bill and provide with the comments relating to it. After we receive the comments, we'll obviously review these comments and make amendments to the bill where that's appropriate. And that will be taken back to Cabinet. Cabinet will, if it approves the bill, then submit the bill to Parliament, and a similar parliamentary process would occur in terms of public hearings after the bill arrives in Parliament. So the public have an opportunity now to comment. They also have an opportunity through the parliamentary process before this becomes law. After it becomes law, we obviously will implement aspects of the bill in a phased manner.
All right. Before we get to aspects of, the implementation part, just to clarify for some of the people watching this program, how then do people make comments? What should they go to some meeting? Should they go to a website? How do they do that?
Well, in the bill, at the back of the bill is an email address or a postal address if they would like to send comments in writing or by email. They could send those comments through commenting on aspects or clauses of the bill. What would be very useful is to identify which clause people have difficulties with in order for us to understand what the issue is with that particular clause and to make recommendations relating to how that clause could be amended.
All right.
We will also be having public engagements throughout the country in various constituencies, where we'll be engaging the public, sharing what's in the bill, and try to get a sense from the public about what their concerns are with the bill.
All right. Let me invite a comment from Sasha. Sasha, you heard all the clips that we played. You're more than welcome to comment if you have any comments. But you've just heard what Dr. Pillay said about the announcements that have been made and the plan around NHI, I suppose universal health coverage. Your comments, do you have any concerns as Section 27?
So I think the first thing to emphasize is that universal health coverage is without a doubt where we need to be going in South Africa. I don't think anybody acting in good faith would suggest otherwise. We have a system, as other speakers have previously said, where we have a very inequitable health system. We have an inequitable spread of resources, and we have serious quality problems. And so moving towards universal health coverage is very important. These bills were published last week, as Dr. Pillay says, and what the bills provide, in particular the National Health Insurance Bill, is a vision of a different health system, a vision of a health system that is coordinated, that is a single system with a single payer, and separating the payer and the provider of healthcare services. So it envisages a huge change in the way the health system operates, and I think that change is really positive. What we don't see from the bill, unfortunately, and we will obviously be looking further at it, and we will be making submissions, and we encourage others to do so as well, but what we don't see is a plan of how we get there, and that's our concern. National health insurance has been discussed for a very long time. The Green Paper came out in, I think it was August 2010. There was a White Paper in December 2015, and now we see the bill. And what we don't really have is a real plan of how we get from where we are now, where we have a system where of the 696 health facilities examined by the Office of Health Standards Compliance, only 5 of them were found to be compliant with 80% of the norms and standards, and where we have a private health sector that is very expensive and inaccessible to many, to a system where we have a single health system that acts in the interests of all. And so that's really what we're going to be looking at. How do we move from where we are now to the equitable universal health coverage system that we no doubt need in South Africa?
Okay. Well, perhaps Dr. Pillay, you might want to comment on that concern raised by Section 27 in terms of, not seeing a definite plan of implementation. Your comment on that?
Yes, I think a piece of legislation or a bill is intended to provide a legal framework by which a new system will operate. In such a bill, we usually do not include a detailed implementation plan. You will note in the bill there is a transitional arrangements clause which provides in very broad strokes what the key areas of implementation would be until we get to the point of universal health coverage and full coverage. What we will be doing, and what's very clear from the bill, as well as the white paper, which should be read in conjunction with the bill, is that there are a number of implementation committees that the minister will appoint that will trash out a lot of the detail that I think Sasha's looking for. And our idea is to bring all of the relevant role players to those committees and to share their views about how we get from where we are now to where we'd like to be. So the bill is intended to provide the framework and the legal mechanism to do that. The actual implementation plan is something we would want to work with a number of stakeholders, including Section 27, to be able to take us to that point.
Obviously, we're going to come back to the issue of targeted timelines, as it were, because obviously, if you look at the SDGs, the target date, as it were, is 2030. And we need to talk about what happens between then and now. But we're going to do that after a quick break. Time for a quick break. Please stay with us.
Violent protests have spread throughout the province for a second week now.
It shows that the ANC here cannot put the people first, and services have failed here. That's why this Northwest becomes a very important province.
We've almost klaar gepraat. Kom. Niks. Ja. Hoor in jou bakkies 'n lighter. Kom, maak sit in jou kop, pak.
Manesa shota haholo. Then manesa ona ha tse bua le gona hantle. At the end of the day, ba bang ke di maternal death and all that, we are to be blamed because of overcrowding ya di patient.
I will build a great wall on our southern border, and I will have Mexico pay for that wall. And nobody builds walls better than me, believe me.
I want to thank and humble myself for the opportunity that was given to me to serve the people by the African National Congress.
The Premier resigning. Now, a new man is taking over the reins.
It's a trust deficit that has widened. I think that has been patently clear from the concerns that people have been raising. So it is not true that there is no money. No, there was no money.
Welcome back. We're talking universal health coverage with my two guests, Sasha Stevenson, Head of Health at Section 27, and in our Pretoria studio, Deputy Director General for NHI at the National Health Department, Dr. Anne van Pile. Before we went on a break, we were talking about, obviously timelines, their plan and so on. But maybe let me start with you, Dr. Pile, and perhaps pick on one or two issues that were raised consistently in the previous interviews, and we've had a question again from Samki, around the issue of quality, whether or not it's perceived differences between the public and the private sector. But what are the plans, or what are your thoughts in terms of how these issues should be addressed around quality of service?
Yes, I think the issue of quality is quite a complex one. If you ask a member of the public around quality, he or she would probably argue that quality is better in the private sector, because an ordinary member of the public using a health system.
Dr. Pile, just apologies for that. I think we seem to have a slight problem with our sound. Let me come back to our Joburg studio and speak to you, Sasha. Sasha, you've had your, obviously we had a question on perceived quality. You've had input from Professor Malakapuru Makhoba on the perceived differences between the public and the private sector. First of all, from your perspective, how do you see this as a problem? Do you see it as a problem at all?
Absolutely. I mean, we speak at Section 27, we speak to healthcare users and health workers every day, and we see quite clearly the issues with poor quality, particularly in the public sector, because that's the area in which we primarily work. There are, of course, also quality issues in the private sector, but I think that the main issue between the public and private sector is inequity. It's availability of resources in the private sector that's not available in the public sector. And so quality is certainly a concern. It wasn't long ago that we established the norms and standards for healthcare establishments, and that's a really important step in improving quality of healthcare services in South Africa, because that allows the Office of Health Standards Compliance to measure on some measurable basis the quality of services and the quality of facilities within the public and the private sector. That will be, we understand, the basis for accreditation under national health insurance. And so facilities will have to have passed certain quality standards. It's so important in a system where we've seen really poor quality in some areas and a real lack of trust by people using the healthcare system that they will receive the services that they require. And I think that reflects some of what Samki was saying earlier. There's concern that really people aren't receiving the quality they should be and that nobody knows. Yeah. And that's what the norms and standards are meant to do. Unfortunately, where we stand at the moment, as I said, most facilities, the vast majority of facilities, don't measure up to those norms and standards. And so now we are in the second phase of implementation creation of NHI, where we are supposed to have gone through a quality improvement process, and we're still sitting with these significant quality problems.
Yeah. Let's go back to our studio in Pretoria and see if we're ready. We're not ready with the sound? Okay. I mean, the other issue, Sasha, that was raised is the ethics of work when it comes to personnel, healthcare personnel. All right. I mean, in some instances, as you quite rightly pointed out, it may be that in the public sector, because of resources, there aren't enough, healthcare professionals in there, and that they overstretch, and that might actually impact on their quality or in terms of how they interact with patients. Your comment on that?
I think human resources is such an important part of the healthcare system, and we often, I think, make the mistake of forgetting that. We often think about healthcare as being about medicines and facilities, but really it's about people. It's about the thousands of people across the country who are providing these services, be they community healthcare workers or clinical associates or doctors or nurses. In the public sector, they are extremely strained. So there is severe understaffing at many health facilities, and also the conditions in which people work are often not conducive to a proper healthcare system. So that's a matter of huge concern. And I think in order to move towards national health insurance, we really need to be addressing that. For example, in Gauteng at the moment, because of historic overspending and contingent liabilities, facilities are only able to fill 50% of available posts, even if they have the budget. And that's meaning that facilities that are already terribly understaffed aren't able to fill the positions that they require. And that's an across-the-board rule. That means that facilities will not have the health staff that they require to provide services. How do we move towards universal health coverage and an equitable health system if we don't have the people to do it?
Okay, let's see if our sound issues have been sorted. Dr. Pillay, are you back with us?
Yes, I'm back with you. Yeah.
All right, yeah, sorry. Apologies for that interruption. Yeah, we were talking earlier about the quality of service, and you started off by saying, I mean, this is a complex sort of area, and I think Sasha picked on the issue of human resources and also ethics of work. Your comments on that, please.
Yes. I think if you ask a patient about the quality of services, one would assess that quality based on things like cleanliness, staff attitudes, the waiting times, etc. And that would be how patients perceive a health system in terms of its quality. There is obviously another aspect of quality, which is the clinical quality of services. So in other words, how well is my health professional treating me? Is the treatment appropriate, etc.? So I think we need to bear that in mind. Having said that, I think Sasha's touched on the issue relating to human resources. And clearly the waiting times in the public sector are much longer. Health professionals in the public sector have a higher burden of patients to manage. And obviously that affects their morale, affects their attitude, etc. The National Health Insurance is intended to buy services from public and private facilities. And we do believe that by allowing patients the access to private facilities as well, the extent of the long queues in the public facilities will be reduced, and the waiting times in the public facilities and the private facilities will be reduced to the extent that patients will be able to access services much easier. That obviously will have a knock-on effect on issues of attitude, for example, because as a health professional that has fewer patients to manage would obviously be able to take his or her time about that and will not be as frustrated as they currently are with the long waiting queues that they have to now deal with.
Staying on the issue of the healthcare personnel, I mean, clearly the one other problem that's there is that of attrition, from the public sector. Are there plans to at least retain staff and attract even more staff back into the public sector?
Yes, I think the issue of attrition in the public sector is a challenge, and that's largely linked to the opportunity to move into the private sector, for example, because the reimbursement is much higher. And where you have a competitive health system, which is a two-tier system, where the rich are willing to pay a higher prices for services, you will have this drain from the public into the private. And so by introducing a national health insurance system, you have a single funding pool by which health professionals will be reimbursed in the public and private system on an equivalent basis. And that would then move away from this current brain drain from the public into the private. So I think that retention within the health system as such will be achieved with a much easier basis than within the NHI.
All right. Your last thought in the last 30 seconds that we have?
I think, as we've said, universal health coverage is very important for South Africa to move towards. The bill is a start. A lot more work needs to be done, and there needs to be transparency around the work that has already been done to develop the plans towards universal health coverage. We would encourage everybody, every user of the health system, whether it be public or private, which is everyone in the country, to look at the bill and to consider making comments on it. This is such an important part of our lives as people living in South Africa, and it's important that we make a contribution to ensure that this bill and this process is as smooth as possible and ensures the realization of the right to health of people in South Africa.
I'm afraid that's all we're going to have it for today. As we heard, universal health coverage, or NHI, is the smart thing to do, and it's the right thing to do. Well, that's all we have for you, and I'd just like to take this opportunity to thank our guest, Sasha Stevenson, Head of Health at Section 27, and in our Pretoria studio, Dr. Anban Pile, Deputy Director General for NHI at the National Department of Health. I'm sure in future, this is such an important topic, we will have future shows where we focus a lot more time on this. And and for you folk at home, thank you so much for watching. Thank you for staying with us. Thank you for the call. And we see you again next week, same time on SABC. And if you've missed any of our previous shows, please remember that you can download them from our YouTube channel. I'm Dr. Selom Luteung. Until next week, please take care.
Violent protests have spread throughout the province for a second week now.
It shows that the ANC here cannot put the people first, and services have failed here. That's why this Northwest becomes a very important province.
Jy wil mos kak praat. Kom. Niks. Ja. Voor in jou bakkie is 'n lighter. Kom, maak sit in jou kop, fuck.
Manesa shota haholo. Then manesa ona ha tse bua le gona hantle. At the end of the day, babang ki di maternal death and all that, we are to be blamed because of overcrowding of the patient.
I will build a great, great wall on our southern border, and I will have Mexico pay for that wall. And nobody builds walls better than me, believe me.
I want to thank and humble myself for the opportunity that was given to me to serve the people by the African National Congress.
The Premier resigning. Now, a new man is taking over the reins.
It's a trust deficit that has widened. I think that has been patently clear from the concerns that we have been raising. So it is not true that there is no money. No, there was no money.